What's up, everyone? Welcome to Physio Monday. We're going to be talking about labrum tears today, hip labrum tears to be more specific. We've got Phil on the show, our resident physiotherapist, so get your questions in and tune in for a good discussion. What's up, everyone? My name is Rad. I am one of the co-founders of Unity Gym and the UMS, the Unified Movement System, where we turn driven people into strong and flexible athletes. If that's something that appeals to you, then you're going to want to grab one of our free downloads, the Flexibility Blueprint, the Strength Blueprint, and the Nutrition Blueprint. There's a link in the description of this podcast or YouTube video, wherever you're consuming the content. And also, if you're not already a member, go over to Facebook and join our private group called the UMS Movement Mastermind, where we record these podcasts live and answer your questions. Now, as always, I am joined by our resident physiotherapist, Phil White. How you doing today, bro?
So well. Yep.
So well.
Yeah, I just had such a great weekend.
Yeah, you did, didn't you?
Spent probably about nearly 4 or 5 hours in the surf, and I was so upset. There was a whale in the surf both days at Manly Beach, and I missed it. I just missed it. But if anyone wants to check out some cool photos, search Manly Beach whale surfing, and there are just some amazing drone shots of these boards surrounding the whale, and know that was nearly me, but it wasn't. So it's pretty magic though. Makes you feel good about the world when something like that happens.
Yeah, that's awesome.
In the midst of dark times.
Yeah, too true, huh? Too true.
But this is a great topic that I'm keen to talk on, and I think we could probably spend quite a while talking about labrums today, because it's a topic that often comes up because it's related both the hip and the shoulder. So we're focusing on the hip today, but there's so much you can take away from the shoulder, and we'll even discuss your experience with your shoulder
for sure,
labral issue as an example. So I think it's a really good one to also just get the basic principles about rehab training. So
before we do that, I just want to give everyone that's watching live a real quick shout out. I can see we've got a bunch of people on here. Can you please just comment in the comments section, just saying hi or anything, so we know who we've got here, and we can give you a shout out, and get your questions in. Any questions, especially to do with labrum, but anything physio related.
Any physio related. There's been not too many people with issues this week that I could see. And if you are putting questions on the UMS Mastermind, I think we must be getting something right here. If you are putting any questions in there, make sure you do tag us, actually getting the notifications up, because Randall, whose questions we're answering today, put our names but didn't tag it, so it's just a bit easy to find it. And maybe even put hashtag Physio Monday or something.
Hi Lee and hi Dave. Thanks for chiming in, and welcome to the show. So should I read out Randall's question, and then we can go from there? So I'm having to scroll down. Have you got it in front of you? Okay, you got it. Okay.
Rad, I was hoping you, Phil, and Yanni could speak about hip labrum tears during the PhysioCast. Mine are classified as extensive tears of the anterior and lateral labrum. And of course, surgery was recommended. However, from what I can tell, surgery is sketchy results-wise, especially for people over 50. Frankly, I'd rather modify and strengthen than have surgery, but it would be great to hear a bit of discussion about this, and if there are alternatives that I should look at, like prolotherapy, joint manipulation, etc. Could just mean my goals from doing splits may move to handstands. Love that thinking, Randall. That's just You've just kind of finished the question so well that your mindset's in exactly the right sort of place. So, I guess to start off, explaining what a labrum actually is probably the way to go. So with both our shoulders and our hips, we have ball and socket joints, which are amazing because they just facilitate so much movement. We can obviously access a whole lot more movement in our shoulder because it's quite a shallow ball and socket joint, whereas in our hips they're quite deep sockets, which is where the labrum sits. And so what the labrum does is it actually just adds a kind of a point of contact. It's made of cartilage that kind of increases the surface area of the joint and basically adds a little bit of cushioning and support. So it's deep into that socket. Now, as I always talk about with rehab principles, is you got to think about whether or not it's an active or a passive structure that you're dealing with, because that really impacts how your rehab is going to be planned. And so when you think about a cartilage sort of, little dish inside the joint, you can tell it's going to be a passive structure, because cartilage, no matter how hard we concentrate, we can't contract our cartilage. So it's really important to understand that for our basic sort of rehab principles, it's all about how can we deload the passive structures, because with passive structures, remember, they're going to be basically like our backup, like end of range support structures, and then ideally our muscles are doing most of the work as they can control the rest of the range. So does that make sense? Are there any clarifying questions?
Yeah, for sure. I mean,
out
if I put that in layman's terms, like the takeaway from everything that Phil just said is, you've got your passive structures, which are the deep muscles that often sorry?
Passive structures are not deep muscles.
No, they're not. No.
Passive structures are the bones, cartilage, ligaments, anything we can't contract.
Oh, there you go. Okay. So I got that totally wrong.
Yes. So I've got to be more clear. But basically, yeah, passive structures we can't contract them. Okay. We can't control them.
So what do you refer to the rotator cuff?
So the rotator cuff is a series of 4 different muscles in the shoulder, and so they're active stability structures.
Still call them, okay, really?
They're absolutely active. Their whole job is to...
Oh, for sure. I misunderstood. See, for those of you that are listening, I'm a trainer. I'm not a physio. So I learned this stuff from Phil, and we've been having these discussions for a while now, and I misunderstood what you said.
The terminology can be a bit funny, but yeah, I try and simplify it to the ultimate degree where it's like, can you contract it? If so, it's an active structure.
Yeah,
so
right.
Muscles,
okay,
tendons.
Yeah. Okay, makes
like
sense.
muscles attaching into tendons.
Yeah.
Whereas passive structures are anything else, so that's going to be bone, cartilage, ligaments, things that we can't control.
Yeah, okay, sweet. So the labrum is a...
Yeah, it's a passive structure. So it's in the...
Is it considered muscle? No, it's cartilage.
It's cartilage.
Cartilage, okay.
It's cartilage. So, it's...
So my slap tear, is that a tear of the cartilage?
Yep. And so with the slap tear, well, this is in the shoulder, you've got your superior labrum anterior posterior, which basically means it's going from the front to the back, and it's on the top.
On the superior portion of it, yeah.
And so the reason why you get a bit confused there about whether or not it's kind of active structure is because it's an attachment site for one of your bicep tendons. Yep. And so there's an active component to it, but it's an anchoring point for.
And does it repair? Does the cartilage repair?
So the thing about cartilage is, cartilage is a very slow to repair type of tissue.
I know it.
Yeah, and like with cartilage, there's very low blood supply to cartilage, so it does take a bit longer with these sort of things. And so on Randall's questions, he's talked about prolotherapy here, which is the type of blood therapy, and Kim
spin the blood.
Yeah, and Kim Engler's come and answered in the question. She's talked about autologous blood and platelet-rich plasma injections as well. So there's clearly a real interest around how to make cartilage repair, and I think to try and not just go into this like big rabbit hole, I think the kind of simplest way of thinking about how to approach a labral tear is, think about what you can do to support the joint itself, and then anything around cartilage repair is going to be a bit more speculative, a bit more sort of, like it would be nice, but there's so much you can do for the joint itself. Because the thing about
can it repair though? Like in the best case scenario, can a cartilage
does
tear
slowly repair, but then age becomes a bit of a factor about it. But there's always things that you can do, and I just want to get we've talked about last week with pain science and how with discs in the back yesterday. But the really important thing to understand is that just because you have morphological change, so change to the actual structure, so if the cartilage is damaged, does not mean that you're going to be in pain. It does not mean that you're going to be limited in your function. So that's the really important thing to kind of wrap this whole conversation in, is that there's like what we can do for joint health, and then there's going to be if the cartilage will heal or not is kind of less important in the end, because really like there's so much you can do outside of that, and your pain is not related to your morphological function. So I did a quick little look around to see numbers around what percentage of people who are pain-free, full function, have labral tears. And one quick study I found from 2012 looked at women in their 40s, and 69% of women in their 40s have labral tears, but like very few actually know about it. Yeah. And so again, like we talked about last week with imaging for lower back pain or back pain, that like so many people will start to develop some kind of pain, go and get a scan, find out they have a labral tear, and then think, aha, this is the cause of my pain. But really, if you'd scanned them like 2 years ago, they probably would have still had that labral tear. So unless your pain is very much related to a traumatic event, so like you've, with your labral tear where you missed re-racking was how you did it, right? Or
No, it was working on a progression for the planche, a calisthenics movement, if you don't know what that is, where you put your shoulder into really loaded, semi-extended, semi-flex position, I guess. And
so that's a really good example of a traumatic instance causing a labral tear. I had one where basically I was playing ultimate frisbee and I was going out for a big catch and someone came in and barged me by the side and subluxed my shoulder and tore my labrum in my
what does it mean when you sublux your shoulder?
So basically, instead of a full dislocation where the joint totally comes out of the joint, it basically like comes down a little bit, goes back in.
Yeah, right.
Yeah, so it's just like the joint kind of gets a bit extended, like stretched but not dislocated.
Yep.
And so that was another example of like a traumatic labral tear. Whereas if you haven't kind of had one of those incidences and it's more of a kind of, insidious onset, or it can be related to like if you've had hip dysplasia as a baby, if you're generally more hypermobile. So I'm on the laxity scale of being a bit more hypermobile with my passive structures. So I'm more prone to tears as well. So there's things that can impact it, but unless you've had like a real traumatic event, it's really unlikely that like the onset of pain is related to when that kind of labrum changed. So a bit of a tricky one here. There's quite a few questions coming in.
Talking what you're talking about here. I mean, I've not the hip labrum, but the shoulder labrum. I've now successfully rehabilitated a very nasty injury that I had in my shoulder. And the process for the rehabilitation was there was no focus on the labrum itself. The whole focus was on the active structures, the muscles, and how I can strengthen different movement patterns and basically just be progressive. And it worked really well for me. I had a really great result without any medical intervention.
Yeah, so I think
actually that's not true. I did get a cortisone injection. Is that what it's called? Cortisone or cortisol? Cortisone. I did get a cortisone injection in the very early stages.
So to be clear, a cortisone injection is a very strong anti-inflammatory steroid.
Yep.
So it's what you use when it's when they kind of want to test if they're going to do surgery, and it's basically, or it's just to get people out of extreme discomfort. But it's generally not recommended to do continuously because especially with tendons, it can really start to weaken the tendons around it. So
it definitely did help me because
as a facilitator for exercise, as a facilitator for active intervention,
and that's how I used it. I should be really clear on that because I spoke to Phil. I got Phil's advice. I got advice from a couple of professionals. And the advice that I got was if you're going to use it to allow you to exercise and rehabilitate, then it is an option. And I used it exactly for that. So anyway.
But I think we'll go into your kind of experience of rehabbing that. Probably we'll just quickly get
go through the questions.
Some of the questions coming.
So Jonathan Leffler's saying, "Hey everyone, finally caught the live video today. That's awesome." Lee Clements is saying, "Can cartilage be rebuilt with supplements, etc.?"
Yeah, so a lot of people ask about the like chondroitin and all those kind of supplements. I think probably I'm not an expert in that side of things. I wouldn't say rebuilt. The very important thing with cartilage is getting the right kind of load as well to stimulate it. So if you want to look into supplements,
I think one of the biggest things to understand about supplements is that if they irrefutably worked, there would be no question about them. And you'd go to a doctor and a doctor would tell you to take it. So at best, supplements are going to give you the smallest amount of if it was something that was the silver bullet, we'd all know about it. You wouldn't be asking this question here. Just in the same way that we know that if you've got a headache, you take Panadol. We know that works. There is objective, clinical research. There is nothing that is that, definitive about supplements. So Eric is saying, I tore the labrum on my left shoulder a few years ago by falling down. Wrong, not fun, and took months to heal. Yeah, I know all about it. Kyle is saying, I did my hip at footy with it trying to pop out my glute. Mechanism was sublux, but didn't pop out. Thankfully, no surgery.
So I think both of these examples are really good examples of an acute traumatic injury where in this case, the labrum is much more likely to kind of be the driver of pain as opposed to those kind of insidious onset, those gradual onset stuff where it's like people get a scan and then suddenly think it's a labrum is the big issue when really it's just like a greater sort of dysfunctional joint.
Yeah, right. Yeah. I don't really think there's any questions there, Phil.
No. Just wanted to kind of
comments.
Clarify that. So with Rad's experience of the shoulder, like just is a really good example of how to kind of approach, a labral rehab in a very active sort of way. So I think maybe if you want to just kind of talk about your
sure. So my experience, so I had an acute injury. I was doing a workout and I felt a sudden sharp pain on one of the reps of one of the sets that I did. I didn't think that much of it. I thought, I've kind of moved around and I wasn't doing any overhead movements. So in the workout, I didn't actually push my arms up to really feel what it was like. So I continued my workout and I finished it, which one of my biggest lessons was, if I ever experience a sharp pain in a workout again, it doesn't matter what I feel during the workout, I am going to stop immediately because I am certain that I did far more damage by continuing the workout and continuing to do the exact same exercise that caused the pain. Later on that day, I had just a chronic pain in my shoulder and I couldn't lift my arm above shoulder height. I couldn't, on the podcast, if you're watching, I'm barely lifting my hand above shoulder height here. And I just thought to myself, I better have an Epsom salt bath tomorrow. I've got some bad DOMs, some bad muscle fatigue from that workout. Over the next week, it progressively got worse, and it was so bad that I could barely move my arm. So I consulted Phil, and Phil's advice was, just keep moving, but really just take it easy and see how it progresses. And I can't remember exactly how long it was. I think it was about. So actually,
when I say take it easy and keep training, like the thing with this kind of stuff is you want to keep the structures active and train in your available range. So Rad had a really clear, certain range hurt him, but within activities within that range. So once you got past 90 degrees, painful, but below that, manageable.
Yeah, and that was definitely your advice. I should have been more specific there. It was train within the active range. I can't remember the exact time frame. I think it was within a month that I could definitely tell it was not improving, and that's when I decided to go and get an MRI. And the MRI showed a slap tear and a torn supraspinatus and some other stuff that it was just, getting older. So I tried then, I got a very specific rehabilitation strategy, and I tried doing that for about a month, and it wasn't improving fast enough for my liking. So I went and got a cortisone injection, and the cortisone injection within a day or two gave me a new range of motion. I could move my arm above my head, so I started really using that. And again, working with Phil, working within my available range and following a very progressive program. And it was that strategy that developed the shoulder rehab program that we now offer people, and it worked really, really well. I just saw consistent progress. And
so the key thing to think about with these ball and socket joints is that when you are moving in any direction, I've talked about how muscles are dumb before, but basically the prime movers, so your big muscles like in your hip, for example, your quad at the front and your hip flexors will bring your leg forward, and your glutes and hamstrings at the back will, be your extensors. Your abductors will abduct, and your adductors will adduct. So you have these big global muscles that are pulling your hip in different directions. But what also happens with ball and socket joints is that these global muscles are just contracting; they're only shortening. And so what that does is it moves in that direction, but also causes a glide within the joint. So the actual ball is gliding within the socket, and so the labrum plays a part in trying to help sort of limit that a bit, but the big job comes down to the muscles that attach onto the ball as well. So in your shoulder, people really
piriformis.
Well, yeah, exactly. So in your shoulder, you have your rotator cuff muscles, and they're the four muscles that sit around your shoulder blade, and their whole job is to we train them as rotators, but really their job is to stop that glide. And so within our hip, we have...
they all originate on the scapula?
Yep.
All of them connect to the scapula and then onto the humerus?
Yep.
Yeah, okay.
Yeah,
cool.
yeah. 3 on the back and then 1 on the front.
Yeah.
But yeah, in our hip, we have heaps and heaps of little muscles, and piriformis is the favorite of everyone.
Personal trainers, yep.
And and I don't know, all health professionals just love kind of talking about the piriformis. And they all attach onto the ball, just like we do have in the shoulder, and they are rotators. So we have external rotators on the back, and we have a couple of internal rotators as well. but their main job really is the same sort of thing. So we're looking at trying to stop the gliding of the joint. So an example of like how this kind of, people who are kicking or when you're sprinting, you're really driving your hip forward into flexion. So if you didn't have muscles that are putting the brakes on that limb, then you'd get closing down in that space. Femoroacetabular impingement, FAI, that you might have heard of before, where you get basically pinching of that joint space. And, if you didn't have the extensors as well, you'd get full-on anterior dislocation. So their job there is to really try and control the ball within the socket, keep it in the middle of the joint, so we have a nice pivot point instead of having a joint that's gliding around and basically bashing up against all the passive structures. So the joint, the bone itself, the labrum, and the joint capsule. So if we can have active structures that are really doing their job, then you get much less bouncing around of like the bone on bone, for a term that I hate. But like, if we can control the bone, then it's going to do much less stress on the passive structures and therefore keep the joint much happier and healthier. So for people who've done sort of hip and shoulder rehab with me, there's a big kind of, the big focus is about basically getting really good balance on the joint as a whole. So keeping, for upper body, for example, keeping horizontal push and pull, keeping vertical push-pull. For some people, it can't be vertical. It will just be, whatever level of incline that you can manage, pain-free range. And then for the hip, it's all about still developing all the kind of good hip strength we do in the Unity program, but then adding in some extra stability work as well.
I want to take a moment here to point out something that really stood out to me from what Phil said just then, and to highlight something that we are always talking about when people ask us, why is the UMS such a good program? When he was talking about that kicking example and putting the brakes on so that your hip doesn't fly out, if you guys go back and re-listen to what Phil just said there, it really highlights the importance of training agonist and antagonist muscles equally, regardless of what your goal is. So, it doesn't matter if you have a really, like for me, one of my big goals at the moment, like something that I identified in my upper body and my shoulder that I've known for my life, but I never cared about it before because I never cared about aesthetics as a driving force for my training. But my chest, my pec major, is quite underdeveloped for the rest of the muscles in my shoulder. And I'm trying to create symmetry in my shoulder now as, I'm out of rehab and I want to avoid this ever happening again. But I don't just train chest. It doesn't matter that is a muscle that I've identified needs some hypertrophy in it. I train 1-to-1 ratio of horizontal pushing and horizontal pulling movements. So for every set, for every rep that I do something that it develops chest strength, I do the exact same amount of sets and reps that develop pulling strength. So what Phil was talking about there, it really highlights the importance of that. And that's a really, when you're going to be thinking about rehabilitating a labrum, whatever muscles you're training, you have to understand how to train the opposing muscle groups as well.
It's all about making the system of that joint so that all the muscles that work together as good and as strong as it can be. Because sometimes people get a bit like, why am I doing all this sort of, this isn't targeted, this isn't rehab. But it's like, well, if you have a system that doesn't work, then
I was like that for years as a personal trainer. As a juvenile personal trainer that didn't understand this stuff, I tried to think, well, I just want to make this better, or if somebody said to me, I want to make that better, I would feed that.
So it really frustrates me when people have like rotator cuff issues, and then they the person who's prescribing rehab just gets them to do external rotations until the cows come home, and it's like, well, you've got a muscle that's like struggling already, and then you're going to overload it with way more training, and then not give the rest of the system like the balance to be able to all work together, so that when you then come back to doing activities, like everything's deconditioned and like you're totally imbalanced, like muscle wise, and it's just no good. Whereas and with the external rotation versus like more dynamic stability work, like the way that these stability muscles work, so the rotator cuff in your shoulder and the hip external rotators and internal rotators, like they have to be reactive. It's not pre-planned stuff. Like you're not thinking that, like you're not sitting there thinking, okay, go external rotators, stop the anterior glide. Like you don't think about that stuff. It all happens reactively, and it all happens within a system of movement. So that's why it's so key to keep your big global movements there, train it within a comfortable range. So I know a lot of people in the Unity kind of tribe get, I don't even call it like movement purists, where people love like an ass to grass squat and they love kind of making it look as like deep and, like really exploring full range, which I'm totally on board for. But sometimes it just means that, to maintain squatting, which is going to be great for keeping your hips healthy. Like sometimes, people will just have to take a bit of time squatting to 90 degrees or even squatting to slightly less than 90 degrees. And that's okay.
Yep.
Like you don't have to be.
It's your available range.
But I've had so many people come in and they're like, oh, I just can't squat anymore. And so I haven't squatted in months. And it's like, they get to 90 degrees, they're totally fine. It's just that last bit of end range starts to get a bit of discomfort. So it's really important to think about how we can keep the system happy and then look at training the muscles in both kind of targeted ways. So with the external rotators of the hip, which help control that movement within the joint. We do a bit of targeted work, so doing a bit of external rotation, a bit of internal rotation, targeted work to like hypertrophy that muscle in that sort of way. But then we also look at getting that dynamic stability. And what I mean by dynamic stability is that reactive stability, which happens when you're doing, single leg balance work. It's, we do a bit of with the shoulder and the hip, kind of controlling a ball against the wall, which seems like almost a nothing movement. But if you kind of slow it down, really get it right, then it's really quite challenging sort of gentle rotation stuff where you have to, really have these muscles very active. So,
Man, that was my bread and butter for my shoulder for 6 months.
Yeah. And then it's all about, even building in sort of more reactive and dynamic stuff where you, like for the hip, for example, like if you're looking to get back into running or anything vaguely athletics, it's like learning how to land, so stepping up a box and sticking the landing, which is more dynamic single leg work, and then looking into, how can you control from like a bounding leap to a controlled landing. So
I love it.
Yeah.
When you start to understand how these systems work together, it's just phenomenal that we can do what we do at the speed we do it at, and most people don't experience any pain or discomfort. Like the way that the body works is just phenomenal. It's unbelievable, and it's really up to us to take care of that and to nurture it. And you get away with a certain period of your life by really not thinking about this, because most people are very active up until late teen years, is where for some people it starts to go downhill when they get into the workforce and they get out of school and they're not running around as a child anymore. But you really want to make sure that you continue to train your body in a way that keeps it healthy. I think
that's a really good example of as a kid, if you're like running around, you're playing tip and tag in America, or you're doing all this like multi-direction, change of direction, playing contact like team sports. You kind of all these structures are being conditioned regularly all the time, just from like playing and life. Whereas then if you go and sit at a desk for 3 months in a row from COVID lockdown and you don't do much activity, then all these structures that are those dynamic stability structures, they've been like, oh, this is my life now. Okay, I can just chill. I can atrophy. I don't need to do anything. And then you start to come back and you try and push end ranges, and or dynamic, quick movement. Then it's going to be like, you can see how that's going to be really challenging. So, just one thing, I just want to cover two more topics on this really quickly. Is a lot of struggle with sort of passive joint injury, so like labral tears, happens in people who really want to explore end range movement, which is this audience. So when you're doing like, total end range stuff, as I talked about before with passive structures, it's very much kind of your like, end of range backup sort of support structures. So if you're really hammering like front splits or middle splits, it's quite likely that you're going to be more aggravating of those structures. So, but I'm totally on board with people pursuing their goals. So if you want to keep your mobility kind of going, I just recommend bringing the movement back from its end range where it's really painful, and then getting as much control as you can through range, and then starting to explore that control through a larger range as you go. Because if you're just going into sort of total passive movement and you're letting your muscles totally relax, then you're not going to have that control that we've talked about.
Which I really want to hammer this point home. What Phil's talking about there is just to really make sure you understand what he just said is, if your goal is flexibility and you've got like Randall and you've had a labrum tear, one of the worst things that you can do is passively try and pull your legs into their end range. And so for those of you that have got it, the loaded stretching routine that we have is brilliant for this stuff. So you're going to end range, but under load, where the muscles are controlling the body, controlling the hip, and you can feel when you get to end range, controlled, not being just pulled there. And then that, you're actually even strengthening the structures whilst you're doing your flexibility training. It's a very, very effective way to safely develop flexibility.
Yeah, exactly. And I think people kind of get this sort of stretching is a totally virtuous and cure-all magical thing that fixes everything. Like, I'm all for stretching, but when you think about passive structure injury, if you're just doing stretching as a way of helping it, then you're really not building up that control and the dynamic strength around the joint. So it's just so key for people to understand that, sort of when people think oh, I've got an injury, I've got to rehab it, most people's minds jump to what stretches do I need? Whereas for this, it's not the case. And for most things, it's really about that balance of getting good movement, but really being able to control that movement through strength.
Yep. So absolutely.
The last thing I want to talk about is basically coming back to those ideas around whether or not you need autologous blood injection and basically also just with pain science, you can see how if you were to take the I'm just going to totally split it in two. If you just went down the getting an injection sort of path, if you get an injection and you don't do activities that stimulate growth and stimulate this improvement in function, then it kind of doesn't matter what you inject in there, it's not going to make the system work any better. So it's so key. I don't really, there's not good evidence to show that platelet-enriched plasma or autologous blood injections do have a big result, but if you do or you don't, you've got to be adding proper dynamic progressive rehab in there. And the thing is with pain science as well, we've talked about it so much before, but you get so much benefit from trusting your body and completing goals and having movements that give you confidence in your body, that if you just went down the injection path and then every day you sat there thinking, is it better yet? Is it better yet? Is it better yet? Without doing something for yourself, without taking control, without hitting kind of strength goals or movement goals or mobility goals, or even just process goals of turning up and doing your rehab, then your brain is not getting a signal that that I've got confidence in this joint. Though in saying that, people are really have such a strong mental placebo result with just going to a doctor and having someone say you're fixed. So you'll probably get a bit of a placebo there, but yeah, just really want to hammer home that it's so important to be for all things pain science and solid rehab principles, you've got to be doing some work.
Yeah, yep. And look, for anyone that's listening, if you want to go deeper into this and you want to understand how you can fix something like a labrum tear, grab one of our rehab programs. They're very well written. They've been written by us who have experienced these injuries ourselves and used them. So in this case,
I have a left labral tear.
Yeah.
I also had that, and I do more sports and activities than most people I know. So
yeah, for sure.
Running, beach volleyball, all this stuff, which is very, impact heavy, but you can do it because, you've got this stuff right.
Yeah. And if you've got any of those programs, go back and revisit it, because we actually just uploaded a new chapter in there for rehabilitation theory that Yanni recorded, and it's really, really good stuff. If you don't have any of them, they're all free and included in the UMS online coaching monthly subscription. So jump on that and join the program. And if you've made it to this far through the show and you haven't done so already, download one of the free blueprints, the Flexibility, Strength or Nutrition Blueprint, and come and join our Facebook group, the UMS Movement Mastermind, where we record this live. Thanks everyone for tuning in. Thanks for the chat. It's great.
We're stopping here. I could just
Phil can just keep going with this one for sure. For sure.
Get aggro with this sort of stuff.
Yeah. Oh, look, it's awesome. I mean, I learn so much from these chats myself, so I can only imagine what our audience is learning. It's
and please, if you're watching and I know I talk a bit fast and I get excited and I kind of go down rabbit holes sometimes. So if you are watching and if things are unclear, please in the comments, or even if you're listening to this after the fact, kind of let me know. It's good to get sort of feedback about how deep to go and how if I'm making things make sense. I try and bring in analogies and try and steer away from complicated words, but I really do appreciate feedback about whether or not the kind of core message is coming through clearly.
Yeah. Well, Phil, it's one of the things that I love about you is that you demystify this stuff, and I mean that as a real acknowledgement of the way that you do things. Like I have spoken to physios and osteos, and even me as a personal trainer who understands physiology and anatomy a lot better than most people. They often talk in a way that makes me really question it, and I love the way
there's power in keeping it like complicated and mystical, because it means that you can get people coming back all the time. But if people understand these core concepts, then it's just it means that as a patient you can go in, you can ask the right questions, you can have a really good understanding of this stuff yourself, and you can kind of take that power back in that.
For sure.
In that dynamic.
Sure. So if anybody listening does need any extra help and wants to do a live online consultation with Phil, you can do that, unless, unfortunately, if you live in the United States, his insurance doesn't cover that part of the world.
It's just the US health system is bizarro, and we can talk to anyone else in the world, but just not people in the US.
Sorry about that, guys. Thanks.
Ask questions on here, and you can get some.
That's right. You can still get some very good general advice. So, thanks everyone for tuning in. We will see you tomorrow for another kick-ass show. Have a great day.
Health is about performance, not just body image.
You better be willing to accept what you're going to have to do to get there.
We'll start focusing on movement goals, strength goals, flexibility goals.
When you nail that skill, it's there forever.
The body image goal doesn't get you that
It's
far.
the consistency and frequency that's going to get you there. It's not the intensity.
There's no shortcuts to mastery and movement. Destination doesn't change overnight, but your direction will.
The gym is not the place to beat up the body that you hate. It's the place to build the body that you love.
We are the gym that teaches people how to move instead of just exercise, because we believe that health is about performance, not just body image.